Hello, everybody. Welcome back to the show. Cameron English here with you as always, Director of Biosciences at the American Council on Science and Health, joined again by our very own Dr. Chuck Dinerstein, Director of Medicine. Chuck, how are you this lovely afternoon?
I'm pretty good. I cannot complain, which is always a treat.
I love it. Well, I can always complain, so I will complain for the both of us as time goes on.
Fair enough.
But in any case, we've got two stories to discuss. Chuck is the author of the first one. I'm the author of the second one. First up, we have Parkinson's disease gets diagnostic help from artificial intelligence. Very intriguing stuff that we're going to get into. And then I have a story about a pretty major concert that took place in 1999 called Woodstock 99 and what that tells us about artificial scarcity and the serious impacts that can have. So we'll get into that later. First up, though, Chuck, tell us a little bit about this story.
Well, I have to say that I came to this article because of my experience doing yoga, because one of the pillars in yoga is breathing. And as it turns out, controlling our breath is one of the two ways that we have of influencing our sympathetic nervous system and toning it up or toning it down. The other way that we have to control our sympathetic nervous system, or at least partially control it, is with eye movement. And there's a large body of literature about how eye movement has been probably the most effective therapy for post-traumatic syndrome and its symptoms. In any case, so once I see articles on breathing, I'm always kind of drawn to them to see what science has to say compared to what the yogas have said, or the yogis have said over the course of time. So in this article, they looked at the breathing pattern of patients with Parkinson's disease. And Parkinson's disease is a neuromuscular disorder. The way I try to describe it in the article is that it results in kind of a staccato movement. Your movement is no longer smooth, but is breaking down into teeny little imperceptible at first, but perceptible over time, starts and stops. And that has to do with the dopamine receptors in a part of the brain. And what the researchers found was that using very simple mechanics, just a belt around your chest that would measure the excursions of your lungs as you were breathing, they were able to very accurately identify patients with Parkinson's, as well as patients that were likely to develop a neuromuscular disorder over the next several years, which is really, for Parkinson's disease, quite a switch. Parkinson's disease doesn't have any biomarkers. There's no lab tests to do to say you have this diagnosis. It's a diagnosis that's made on a clinical basis, and because it's clinical, it's somewhat subjective. And it's very difficult to follow, because if you think about it, and I try to measure your weakness in January and then try to compare it to your weakness 12 months later in December, I don't have any good objective frame of reference to say whether it's stronger or the same or worse. So this kind of a technique can make a huge difference. So basically what the researchers did is they took a group of patients where they had done sleep apnea kind of tests on the patients, and where they knew which percentages of them developed Parkinson's over time. And they went back and they looked at their breathing patterns, and they submitted those breathing patterns to an AI program. So AI programs are basically very fancy computer ways to do pattern recognition. The difficulty with this particular form of AI is that it doesn't tell you what pattern it found. It simply says this falls into that pattern or it doesn't fall into that pattern. So it's a little bit of a black box, and that's always been a problem for AI, that black box quality about it. But what they found was that looking at these basically non-invasive measures, they could identify with an accuracy of about 90% people that had or would develop Parkinson's disease over time. Now, let me qualify that. They couldn't say for sure that they would develop Parkinson's disease, but they were relatively sure that they would develop a neuromuscular disorder. Parkinson is part of a range of neuromuscular disorders. Moreover, they could use that same information to follow them on a year-to-year basis. So they had a way of objectifying the change in the patients over time. It doesn't provide these patients with any immediate benefit, but having something to measure now allows physicians to begin to a little bit more rationally adjust medication doses and know when to start and to stop medication. So in the world of Parkinson's, where there's not been any good treatments or any kind of rational approach to management, this is a big deal.
So just a little bit of background. How good are physicians at diagnosing Parkinson's as it stands? Because I know you said it's inherently subjective because you're relying on a physician to diagnose it, during a physical examination. But my experience, and of course I don't have any clinical experience, but as a parent, for example, when I go to the pediatrician, the doctor's very skilled in what she's able to identify, so I can go to her and say, what is this? She can go, oh, it's that because of, my many years experience. So I'm wondering, how do those variables work in this context?
Well, again, you're talking about very slight early changes. So if you ask me, once they have full-blown Parkinson's, we're very good at picking it up. No problem at all. The difficulty is in picking up early stage Parkinson's, where you might find that intervention makes a difference. We don't know because we can't identify early rather than late. Until the symptoms become apparent and persistent, our track record diagnostically is not very good. We can be suspicious of it, but it's really a clinical diagnosis. We need to see how the patient's neurologic status changes over, say, a 3 or a 6 or a 12-month period of time. Now, if their changes are very slow, you may not pick it up for 2 years. If their changes are more quick, you may pick it up in 3 or 4 months. But that's only because it's becoming more apparent to everyone that there's a difficulty, rather than some magic diagnostic tool that we have. And that's one of the beauties of this test potentially, is it makes it much easier to make the diagnosis. If I have a suspicion of it, I simply can give you one of these belts to wear and take the data from a one night's sleep and begin to make a diagnosis.
Okay, so this is a big deal. It sounds like it's a solid improvement in how you're going to identify people that may be at risk for this. But as you mentioned, we don't have any great treatments for this. All right, I don't think there's really any sort of preventative actions you can take just yet. Correct me if I'm wrong, but
no, you're correct.
Okay, so what do you do with this information in the short term until we develop, an effective intervention?
In the short term, it may help us better manage the medications that we have, which are basically L-DOPA, to give some dopamine to the system. A big hammer for the problem. It's not strategic. It's not certainly a strategic a therapy for Parkinson's, but it may allow us, number one, to identify patients objectively earlier, start therapy earlier. We may find that makes a difference in terms of the trajectory of the disease, how long we can keep them comfortable. Okay. Versus we may also find that there are situations where going up on the medication is not making any perceptible difference, and we can stop that. It's finally providing us with an objective measure that doesn't rely on the experience of the neurologist that's seeing you. And that's its big claim there. There's two other claims that we can make about it that are important. From my point of view, this is the first piece of artificial intelligence that actually has any big value. I mean, the Apple Watches and picking up atrial fibrillation on your wrist is not anywhere near as significant a diagnostic improvement than this. But, Apple's behind those watches, so there's a big push. And when you talk about AI, that's one of the first things to come through. And this test way outshines any of the clinicians. We're not, when you look at AI compared to radiologists, because AI has made use of a lot of images, so they've done a lot of work in diagnostic radiology. AI is just as good as a radiologist. Not better, just as good. In this case, we have something that actually is better and that physicians can now use as a tool to extend their clinical reach. The other nice thing about it is that this is a non-invasive, very simple means of getting a measurement. It's not a lot of blood work. You don't have to come into a center for a fancy test. In fact, in the study, they talked about using this belt that you would wear while you're sleeping. And in a smaller subgroup, they used radio waves and would bounce radio waves around your bedroom and could detect the movement of your chest simply with the radio waves. And last week, there was another article, which I'm sure is from the same group, talking about using those radio waves to monitor Parkinson's patients in their home and identify people that had problems with their gait in addition to difficulties with their breathing, simply by the means of radio waves. That changes things to a very large degree for people that are living outside the catchment area of a tertiary hospital that does this level of work, because you can deliver to them the means of doing at-home diagnostics and at-home maintenance. And that would be a big win for healthcare, especially in the areas where, I'm going to start calling it the physician deserts, where there's less physicians in the rural areas, and certainly in some of the suburban areas that don't have the expertise of these kind of neurologists.
So that's potentially very, very exciting then. And this is a rough comparison, but it might be something on the level of maybe a glucose monitor, where, someone can measure an important...
Absolutely. That's perfectly good example.
Okay.
Except there's not as many Parkinson's patients as patients with diabetes, so there's a different marketing approach, but that's correct. I think you're going to see with the glucometers, the glucometers are going to make a big difference in the long-term care of patients with diabetes, because now they're going to have a way to follow their own habits. They're going to see what foods cause them problems, what activities cause them problems. And I think that you'll see over the next few years some algorithms laid on top of that information coming in that helps assist people make some choices about what to do. I think that's going to be another huge area where we're going to see some significant improvement.
Well, that leads to my next and my final question, because there are certain exposures that have at least been suspected of causing or contributing to Parkinson's disease. So one that's gotten a lot of attention in recent years is, certain herbicides, for example, so pesticide applicators or farmers or anyone that works in agriculture, if they're exposed to a particular chemical, there is some speculation, there's not very good data on it, but there's some speculation that this pesticide exposure could increase your risk. So I'm wondering, could you use a sort of test like this to say, maybe there's particular subpopulations that we should focus on to see if they really do have an elevated risk for Parkinson's? Is that something we could make use of with this technology?
Yeah, I think that, I think that's another great application. Again, the beauty of this is that we have a way to measure the presence of a problem in a relatively objective way, and certainly in a non-invasive and minimally expensive way to do. So I think that would be another great place to do it. Now, the problem, of course, would be that, as I said, this test is accurate in picking up changes in the neuromuscular tone, but it's not diagnostic of Parkinson's. It's diagnostic of any of those suite of diseases that Parkinson's belongs to. But to your point, I think it would be a great way to follow some of these populations and see whether there's something going on. Pick it up a lot earlier.
Yeah, that just seems to make sense. Instead of relying on a case control study, for example, where you have to ask people who are already sick, how much top 40 radio did you listen to and how many jelly beans did you eat? And right, instead of that methodology, you could employ something like this.
You can do it prospectively.
Yeah. Hone in statistically on what may be contributing to it. But that's really interesting. Is there anything else people should know about this before we move on? Because this is really, really interesting stuff, I think.
I think we've hit the highlights of what's there. We're going to continue to follow AI because I think it's a very interesting area. It's been a lot more smoke and mirrors than it's been useful. This is, as I said, one of the first times that I've seen something that really looks promising for this kind of work.
Very good. Yeah, I'd like to talk about some of the other medical developments or lack thereof in this field, because it seems, and I've heard other people say this too, that there's a story to sell. The coming singularity is it's either really exciting or really scary, and so people will buy newspapers and magazines that talk about that, whether or not it's entirely made up or what have you. So yeah, let's definitely return to that in the future. But let's go back in time a little bit and talk about this Woodstock 99 festival. And that's really just a jumping off point for what I want to talk about, which is artificial scarcity. But if you listening out there don't know what I'm talking about, this was a major music festival in 1999. It was held in Rome, New York. There were somewhere between 250,000 and 400,000 people in attendance. And if you remember the news headlines, the whole thing just ended in disaster. It ended in rioting. People were lighting cars on fire. They were blowing up vendor trucks and vendor booths. They were stealing cash out of ATMs. People got really, really sick because there wasn't sufficient access to fresh water, and there was insufficient sewage and sanitation services. So there was trash everywhere. You had sewage mixing with the fresh water. So people were waking up at the end of the festival with trench mouth, which is caused by drinking sewage contaminated water. And it was over 100 degrees. This was in Rome, New York. I think that's pretty close to you, Chuck, relatively speaking, but
it's closer to me than it is to you for sure.
Fair enough. I'll grant you that. Yeah. But it was held on an Air Force base called Griffith Air Force Base, which of course is tarmac. So in the middle of summer, not only is it hot, but then you have what's called the urban heat island effect, where all of this infrastructure retains heat overnight. So it's just a god-awful setting. There's not enough water. You couldn't bring in food or water. The prices of everything was exorbitant. So people are being gouged. They're pissed off about that. They're hot. And they're just living effectively in squalor for 3 days. And so that explains why the thing collapsed. But what I wanted to talk about is how that is sort of a microcosm of what happens when people who consider themselves nice, upstanding citizens who will help their neighbors and treat people with respect, what happens when they end up in the situation where they don't have enough food for their kids and they don't have access to fresh water and they're suffering heat stroke and maybe they're dying of hyperthermia, right? So you get into a sort of Lord of the Flies situation here, and there's some parallels here that we can talk about. But Chuck, what are your initial thoughts on this, just as a comparison?
Well, I think you're correct. It's the very thin veneer of civilization that we have that falls away quickly when we start talking about vital needs like housing and water and food. I'm thinking back to one of the big storms we had on the island out here, and it knocked out power for a week, and it was making people crazy because the first thing that went that we didn't think about is the fact that you can't get gasoline because all the gas stations work off electrical pumps and none of them had generators. So people running around trying to, get gasoline was a problem, let alone water or any supplies. We live in a very strange time because so much of our vital infrastructure is invisible to us. And we just take it for granted. And 50 years ago, many of the things that we take for granted weren't even there. And that makes it difficult for us. That makes it difficult for us to support that, the sexy idea of building roads and tunnels and any of the other things that we really need.
Well, what's so fascinating, and at least in the developed world, we haven't experienced a kind of cataclysmic event. Not really, like sort of a music festival turned into chaos. We haven't had that. We've come close to it. We've had some things that are similar, but we do have policies in place, or that will be in place very soon in a lot of places, like in the European Union and even some places in the United States, that push us towards an outcome like this. And that's what really scares me. So out here in California, for example, as I mentioned in the story, we're experiencing a drought and there is a water shortage, but a significant part of the shortage is caused by the fact that half of the fresh water that we collect just goes out to the Pacific Ocean, because there are environmental groups who have said, we need to preserve water for natural uses and because we have to save the guppies and whatever else. And this has persisted despite the fact that you have people who don't have access or don't have enough access to fresh water. And the way the media discusses the issue is to say, well, we're just overusing it. Our agricultural use is crazy, even though, of course, residential and agricultural use of water in California has been declining, which is very, very interesting when you think about it. But all that to say, you have a situation where scarcity has been imposed on people artificially. And so far, everything is okay, relatively speaking. But you could have trouble on your hands if we push this a little too far, and that's what concerns me.
Well, I wouldn't disagree at all. In fact, I think the better example is the initiative by the state of California to go all electric on their vehicles, which is fine, all good. But where is the infrastructure to charge all of those vehicles? Doesn't exist, and there's no plan that I'm aware of to bring it there. And even if they were to put in all the charging stations, where is all of that electricity going to be coming from? Are they going to go back to nuclear? Because they're not going to get it from the wind. They're not going to get it from solar. And then so they're going to be back to using fossil fuels in another way. And, I think that the legislators are just more inclined to pass legislation that feels good than actually has any basis in real life engineering. We don't even have to talk about science with air quotes around it, just in terms of basic engineering. The same thing, for a different example, is true in New York. We have 2 tunnels under the Hudson that connects New Jersey with the island of Manhattan. And they've been trying to get the money for a third set of tunnels to go to this population of 8 million people for over 10 years. And finally, after 8, 9, 10 years now, they finally got approval to go ahead to do it. If anything was to happen to the Holland or the Lincoln Tunnel, it would be chaos. And a scarcity that we put in place because we don't want to spend the time or the money on the things that are invisible to us, but that make our lives as blessed as they are.
It's fascinating as maybe as a psychological study or a sociological study, what motivates people to do what they do. And one thing I always found sort of amusing, but also quite annoying, is that the people who come up with these grand world-changing designs, they always say, we're going to do it in 15 to 20 years, right? So California's ban of gasoline-powered vehicles, it takes effect in 2035. So the governor's not going to be in the same position. The legislators aren't going to be there. Whoever's at the California Air Resources Board right now, probably not going to be there. Maybe some of the lower level bureaucrats and scientists will be there, but the leadership will probably be gone. Yeah. And so that's what's so funny to me, is that these ideas are so great, but you're going to deal with them after I'm gone. And then if they fail, I'm not there. And if they work, well, then I'm going to tell you how smart I was for coming up with it when I did,
Right.
So there's sort of like they're hedging their bets in a way, but they're sort of implying that something might not work. And that's why I've pushed it out, a decade and a half.
Well, that's part of it. I think, there's a quote and then there's a piece of economics that goes behind it. The quote that I like the most is that a lot of these people had 5-year plans on a 4-year contract. And, all the good news was coming after the contract was completed. After they'd been paid, after they were gone, then the good things would happen, not to worry. But the way we describe it economically is the concept of temporal discounting, which is I will happily pay you on Tuesday for a hamburger today. And the politicians do that. They are more than happy to garner the headlines today about all the good things that will happen in 2035, because they're not going to be there in 2035 when that doesn't happen. You're right.
There was one other quote from my story, and it comes from a risk expert named Dr. David Zarek. He's in the European Union, and he's been very, very critical of their farm to fork proposal and some of these other agricultural initiatives. And the basic idea is they're going to require, I think it's a 50% reduction in the use of synthetic pesticides. I think it's by 2030 or 2035. And they want a 25% increase in organic agricultural land. And the trouble here, and Chuck, you've written a little bit about this over the last year or so.
Yes.
The problem is that this is going to require an expansion of farmland in poorer countries, because Europe won't be able to grow the food it needs. It really can't do that now, as far as I recall, if I'm remembering that correctly. And then, of course, cutting pesticide use is a problem, because if bugs and microbes and all the other stuff that wants our food gets it before we do, well, then you have to grow more, which of course requires more inputs and requires a greater environmental footprint. So there's a lot of problems here, and the academic literature is very clear on this. The experts have pointed this out ad nauseum, and the politicians and the advocacy groups, they either don't care or they're not capable of understanding. So what are your thoughts on that, since you've talked about this a little bit?
Well, you're correct. I mean, if the more we go to organic farming, the less productivity there is per acre, the more acres you're going to have to put under cultivation to feed the same population. That seems to be pretty clear at this point in time, and we don't seem to have an answer for it. So you're 100% correct in that way. I think that there's a basic disconnect between the academics and the advocacy groups that make use of models to describe things and how they play out in the real world. I mean, and it's not simply limited to the people that are concerned about global warming or getting rid of fossil fuels or advocate for this position or that. It's a general problem when we talk about taking a scientific model that we've tried. Take any of these simple public health measures that we've done that you can do on a small scale. Scaling them up into the real world is far more difficult, and it involves far more things than were involved in the original, project that showed things could work. There's a book called The Voltage Effect that really goes into talking about this problem of transition from small, well-controlled studies to real-world policy. And it cuts across all of our policies that when you don't take into account the real world when you do the study, then you have a voltage drop. You don't get the same benefit in the real world that you got in the small contained study.
It's a very, very good point. Sometimes things don't translate the way that you would hope they do. And then sometimes you're not willing to acknowledge that they didn't translate, or at least that you were wrong in your projections. That's always interesting to me. The quote from Dr. Zarek I wanted to mention, And this goes back to what we were talking about at the top of the story. He just says very frankly, Western affluence and prosperity can disappear in a heartbeat through irrational policies. And that's really the key. And you were getting at this point just a minute ago, Chuck. And I think the problem is no one likes to talk about trade-offs, which is an economics concept. In science, we like models, and in politics, we like grand ideas, and we like saving the world. It feels good to virtue signal in this way. But nobody wants to talk about, when we cut our fossil fuel use in half, or we just outright ban gasoline-powered cars, what's going to happen? What's the cost going to be of that? And nobody really thinks about that. It's not that you're denying there's a problem that has to be addressed. You're just simply saying, how is the solution going to work? And that's the thing that I think we're stressing here.
I couldn't agree more. The other example I would just came to mind is the electrical grid in Puerto Rico that they've spent the last 5 years trying to rebuild, which disappeared in 24 hours. Because they never really built resilience into the new system. They just kind of fixed what was there. Nobody sat back long enough to figure out a better way. It's craziness.
It is. It's quite strange. And, I'm sure there's some difficulty that goes along with being in one of those positions. As we've talked about before, it's harder to solve something in real time as opposed to Monday morning quarterbacking it. But it still seems for some of these things, you should be able to look a decade into the future. So another example is the power crisis in Europe right now. You have the war ongoing in Ukraine. You have energy exports from Russia being restricted, and they could be restricted further. And so Europe is in a bad way. And even now, even while they're going into winter with the risk of not having enough energy or paying exorbitant prices for it, they're still shutting down nuclear power plants. So I'm looking at that. I'm going, somebody is not thinking this through, or it's somebody who's not suffering the ill effects of their policies. I can't really figure out what else it might be, Chuck.
I think you're right. Well, it's going to be an interesting winter, I think, overall. And I think that if Europe suffers significant energy problems over the winter, which it looks like they might, there's going to be a lot of rethinking about policy, both foreign and domestic, in terms of their energy use and where they get their energy from.
That may be the silver lining. Obviously, the consequences we don't like, and we want to prevent them if we can. But if you can't prevent them, maybe that is what it's going to take for people to go, this is a bad idea what we're doing here. But in any case, I would encourage everyone, check out both of these articles. I think mine's pretty good, if I can be so humble, and Chuck's is excellent, just for the insight into how technology is gradually, at least, improving certain aspects of healthcare. But if you want to get these stories that we talk about on the show, just go to our website. It's acsh.org. Go up to the subscribe tab at the top, punch in your email address, and 3 times a week we will send you the stories that we publish. And then the ones that are most read, we bring here to the podcast and we talk about, so you can be a little bit better informed. You can follow the organization on social media. We're on Facebook. We're on LinkedIn. We're on Twitter. It's just at ACSH.org. Thank you all, as always, and we will see you next time.